So, good afternoon, colleagues, and welcome to the 2025 series of the Echo Ukzn Outreach Program. I'm Sarila Ramklas, and I am the manager of the Echo Outreach Program. So, maybe I should just give you some background for those of you who are new on the platform today. This is a collaborative platform amongst the School of Clinical Medicine, the Department of KZN, Department of Health, Echo India, and the Echo Institute at the University of New Mexico. And what this collaboration does is that it enables specialist faculty from the School of Clinical Medicine to share expert knowledge with healthcare workers managing patients at healthcare sites within KZN. So today's session, titled Craniofacial Abnormalities, is hosted by the Department of Plastics and Reconstructive Surgery. Dr. Osman is going to be the facilitator of the session, but I think she's going to join from another platform. But before I introduce you to the speaker, may I just ask that you just ensure that you maintain etiquette for video conferencing, ensure that your name is visible on the participant list. Keep your microphone on mute, please. When not speaking, raise your hand or post your questions in the chat during the Q&A session. So I'm going to introduce you to Dr. Lukama, who is a consultant in the Department of Plastics and Reconstructive Surgery. And over to you, Dr. Lukama.
Thank you very much. And greetings to everybody that is logged on online. I am privileged to be speaking to you about a section of plastic and reconstructive surgery that is not commonly discussed. Most people talk about plastic and reconstructive surgery to involve mainly cosmetic surgery with Botox and breast surgery. But today's talk is going to be looking at craniofacial abnormalities, which is quite rare. But it's certainly an area that I have great interest in. And thanks to my professor, Professor Dyer, who is the acting head of Department of Plastic and Reconstructive Surgery, he has tasked me to give this talk, and the facilitator, Dr. Osman, as well, who's helped as well to put together this talk. Now, when it comes to this type of surgery, it's all about learning, and it's involving education. And the great minds of our past have always spoken about education as being a very powerful tool, and a tool that we should continuously seek to improve on, continually seek to share and to study. And one of the nice quotes that I like is one that is by Ms. Wilde there: "The joy of learning is as indispensable in study as breathing is to running." And this is the attitude that we're going to be doing this talk today. Because craniofacial abnormalities is quite wide. It ranges from cleft lip and palates to a multitude of abnormalities that involve the craniofacial skeleton, that can be quite severe and also can be quite subtle. But all have got its place in terms of their need for management. And quite importantly, they need to be referred appropriately and timeously so that intervention can be given to the respective patients. Now we're going to be starting off with cleft lip and palate. The mechanism of this, just to give you background, is there are quite a lot of theories. And the reason there are a lot of theories is because there isn't one specific answer to it. And however, there are very specific distinct entities when it comes to cleft lip and palate. So one can get a bilateral cleft lip and palate, as we saw in the picture before, this patient here, and you can get a unilateral variety as we see in this image here as well. And I've just put up their percentages of how often this occurs. With the bilateral variety, you find that it is usually about 46%, which is the most common, and 33% in just cleft palate alone, so that's inside the mouth, which we can't see, and then cleft lip alone is about 21%. In Africa, we have the lowest incidence in terms of racial distribution. Africans is 0.5 to 1,000, and the highest is amongst Asians, which is 2 every 1,000. The overall incidence is 1 in 750 live births. This is statistics from abroad. However, the local statistics actually match these numbers as well in South Africa. So it's quite common. And then these type of abnormalities are often associated with syndromes. And these syndromes we need to also look out for and be able to assess the patient as a whole in order to be able to pick up any other abnormalities. And this is where working in a team matters. In KZN, just to sort of run it down, these were the stats from Stats SA. We are sitting at about 293 patients that are born with a cleft lip and palate in a 12-month period. And so it's quite a high number. And so all these patients, those 293 patients that we end up getting to see within our institution between Albert Lutsuli and Pietermaritzburg, this is the institutions that have plastic surgeons. We often have to discuss with parents, how often does it occur with the next child if you've had one? If you haven't had, how often will it occur? And this table illustrates that, just signifying that if you have a parent with a cleft lip or palate and an affected child, the percentage chance to get another child with the same abnormality is 17% for cleft lip and palate, and 15% for just cleft palate alone. The lowest incidence is if you have only one child with a cleft lip and palate, and those numbers go down to about 4 and 2% for your subsequent child. Genetic factors, there's quite a few genetic syndromes that are associated with this abnormality. But importantly, maternal smoking increases the risk twice. So it's important to advise mothers, particularly in the primary healthcare setting, about these risk factors. The use of phenytoin, the lack of use of folic acid and multivitamin supplements. These are the important things to stress at your primary healthcare level in order to prevent such things as your cleft lip and palate. Just quickly going over anatomy, for those who are interested in it, we looking at cleft palate, you can see that the abnormality is a cleft. It's a division between the normal anatomy on your left of your screen and the cleft on the right. And you can see that the alignment of the muscles is abnormal. And then we then endeavor to rearrange this in surgery in order to align them back to what would look closer to the image on the left. When it's on the lip itself, you can see there this image also shows the muscles that are around the face that make up the lip. And this is the abnormality of a cleft lip. In this case, a unilateral, so it's only on the one side. And then we then, in plastic surgery, then begin to realign those muscles and then the skin in order to create an oral continence. And then the patients are able to feed, are able to speak. And this is due to the muscles being back in the correct positions. The nose, in terms of breathing, is also affected. And so when we look closely, you can see the abnormal shape of the cartilages of the nose. And then you can see that on the right of the screen, this particular patient would have had a cleft lip on the left side. I know this because you can see that abnormalities are mainly on that left side. And so we then correct this in order to align the airway passages. And this is important for breathing. And we know that in children, they are obligate oral breathers, so that it's not particularly a problem when they're young, but when they get older, if you do not do this correction, then it creates a problem with breathing. Speaking about children getting older, you can see that this is a timeline of the management of patients with a cleft pay problem. And it starts right from prenatal diagnosis. So once we are able to diagnose it during pregnancy, there is an entire stepwise fashion that we then begin to endeavor to do. And importantly on this slide, it's important to realize that it goes right up to 17 years of age. So our management of patients is for quite a prolonged period of time. And you can also note on this slide that it involves multiple different specialities and allied health, including your speech therapists, the ENT, the orthodontics. We are all involved. Pediatricians are all involved in this management. And so interdisciplinary interaction is vital. Now, I've just listed here in KZN, some of you have a patient. It's important to note down that KZN Children's Hospital, that's the number there on your screen, and you can be able to phone this number, and there will be your first port of call, and they'll be able to assist in order to direct where to send the baby, and then screening can happen there. Another is to contact plastic surgery directly via Vula, and I'll give you how to be able to connect to Vula later on. And I got permission from the geneticist, Dr. Tirona Naika, who has kindly said that if you need to contact her, please call Albert Luchuli, and she can also facilitate this. So there's multiple avenues that one can use in order to get our patients help as soon as possible. Now, how will you recognize if your patient needs help? Fortunately, with cleft lip and palate, when the baby is born, you can see the abnormality quite clearly. And I've just saw some pictures earlier on. And here is just pictures again of a kitty then with a cleft lip. And then you can refer this patient. You can see the drawings that I've also illustrated on this slide. They look like scratches and scribbles. However, these are very particular type of incisions that we make in order to recreate that lip. And then once we recreate the lip, secondarily to that is also to create as minimal scar as possible. And so below that, you see that at the end of the reconstruction, the baby has just a fine line scar that is seen and illustrated there as well. And these are different descriptions of techniques from A to E, and I won't bore the audience with each one of those. This is an example of a picture of the cleft palate. And this is, like we saw earlier, the cleft in the midline of the palate, on the inside of the mouth. And this is then a slide just to show how we are able to actually realign those muscles. You can see on the right of your screen, the muscles are coming back, alignment in the middle. And then we also then suture the mucosa. This is important just to understand the complexity of the surgery. And this is what we'll need to actually explain to the moms, particularly right at the beginning when they're wondering about what is all the fuss about, what's going to be happening. It's good to be able to actually just give them an idea of this. When they do come to plastic surgery, we of course continue to counsel them and give them more detail. But for purposes of this talk, this is just to illustrate how we do the reconstruction. I'll just highlight particularly our bipedical flap and our unipedical flap that we use in order to do a Z-plasty, which increases the length of the palate, which is important for speech and it's important for swallowing. We're going to move on to the next section of the craniofacial abnormalities, which is fibrous dysplasia. This is an immature and haphazard growth of bone in the head and neck area. And it can cause quite a bit of pain, it can cause fractures and a functional impairment. The majority of our patients we will see when they are below 30 years old, and it's more predominantly seen in females than in males. There is a subdivision, it's classified as monostotic as well as polyostotic. So this is involving just a single bone or a multiple bones in the head and neck area. as well as other signs from in the body, and I've listed them there. So when we see a patient in the primary healthcare setting with kyphoid or spots, swelling on the head and neck area, scoliosis, one then begins to suspect that they may be having a part of the syndrome of fibrous dysplasia. Now, when it comes to investigations, the X-ray is quite useful in order just to see the abnormal bone. However, once they reach Albert Litsuli, we often employ CT scans in order to investigate these patients. Importantly, here on the slide is just showing that, highlighting the fact that a lot of the patients, the growth stops before 30. However, there can be malignant transformation. So just to having a growth, an abnormal growth on the head and neck area can become a sarcoma, of which it can be a very serious eventuality, and this will require surgery more urgently. So it is important for us to refer patients as soon as possible. So if in doubt, it's better to discuss, and then we're able to actually then manage these patients. This slide here just shows the different areas in the skull bone that can be affected by fibrous dysplasia. And it's then divided into 1 to 4, as you can see there. And the importance of this is really just to highlight the different areas in the skull. And when those areas are affected, and the associated structures in those areas can also be secondarily affected. And I'll go through that in a little bit just now. Other important differentials that we think about when we see these growths in the craniofacial area is meningiomas, myelomas. It can also indicate metastatic disease. So fibrous dysplasia being one diagnosis, however, we actively look to exclude our differentials. Then the management depends on where in the skull that it is involved. If it's only one bone or multiple different bones, we can employ medical treatment, which is bisphosphonate therapy, or it might require surgical treatment, which can be conservative, or it can be quite radical, of which excision as well as a reconstruction may be required. This slide is quite a busy slide, but it really just divides the different zones of anatomic location for fibrous dysplasia. And I'll just highlight zone 3. And in this zone, I'll just take you back here for a second. So there's the zone 3 you can see on your slide, indicated by the number 3. This area here, you've got the optic nerve that can be compressed. So if you have a growth in this area, this can affect the eyesight, right? And so this is the cranial base as well. So then this can affect the brain. And so observation is also an option here because of the close proximity to these vital structures. However, if the patients are symptomatic, we can also then go into decompress, but importantly without affecting these other vital structures. The other important one, which can also be quite visible immediately, is your zone 4, 4A and 4B, which is your mandible and your maxilla. I'll show that here. So here you can see that abnormalities then can affect your dentition, and then it's important for us to be able to then do an excision, and then we would also consult with our orthodontics, and they can also then help to realign the dentition, as we can see in this slide. So management really depends on where, which bone is involved, and then we then tailor management based on those structures. And then this management also then is something that will then continue for a period of time until we get all the facial skeleton. The next part of the talk is about the skull abnormality itself, so craniosynostosis. Now we're going further up onto the skull. Now here, craniosynostosis is defined as a premature fusion of one or more of the cranial sutures. And just as a reminder for those who have forgotten, you've got your metopic cranial suture that is shown onto the right of your screen, the coronal that is going as well as... Sorry, do you mind muting yourself? Okay, I'm muted. Please do not unmute yourself. So this is just a slide to remind us of the different sutures. And there it's, I've also just illustrated the different types of craniofacial abnormalities that can occur with craniosynostosis. So the growth or abnormal growth of the skull is dependent on where the fusion, the abnormal fusion is. And so this is usually then perpendicular to where the fused bone is. All right. Okay, so with the skull abnormalities, you can get where a variety where there is a fusion of the bone itself, or you can also get a variety where you get positional. So there's no fusion, but there is an abnormal skull shape itself. And this is called positional molding. And this slide just illustrates the difference between the two. So when one is assessing for craniosynostosis, one needs to be mindful that it may not necessarily be a particular abnormality that's related to synostosis. So this slide, I've just included all the different types. Again, it's a repetition of the previous slide, just with an illustration of an actual patient and the shape of the skull, the abnormal skull shape that's associated with the abnormality. Now, when it comes to the incidence, so you find that I spoke about other abnormalities that are associated with craniosynostosis, and these abnormalities occur in about 20 to 25%. The majority of patients do not have any other abnormalities that's associated with it. However, it is important to still look for them, and this is in 80% patients they won't have it. There will be syndromics, in fact, to 80%, and then non-syndromic is 20 to 25%. Other etiological factors or other causes that one can look for is radiation exposure, metabolic disorders, as well as exposure to drugs and toxins. And I've just also included there the different syndromes that can be associated with craniosynostosis. In order to manage these patients, again, it takes quite a team of specialists, and I've just listed there to illustrate the importance of an MDT, a multidisciplinary team, to manage these patients because they are often quite complex. So referring the patients on is quite important. Then when it comes to the management itself, the management is based on which of the bones is actually fused, and the principle is that one needs to allow for brain growth, and then this will, so then these bone cuts that you can see illustrated by the dotted lines then allows us to be able to give space for the brain growth and being space for development for the child. Then this is tailored based on which of the sutures are involved. And I've just illustrated these in these slides as well here. I'll just stop here with the plagiocephaly and just to illustrate here the this is just to illustrate here then when we then do these surgeries, it's quite a complex elevation of the skin as well as then the bone, and then we can be able to elevate the frontal bone and then extend the bandeau that we call it, which is your orbital rim, and this gives more space for the orbit as well as your frontal bone growth. Another area of craniofacial abnormality then would include in the skull itself, and this very interesting slide is just the different areas where the abnormalities can occur, and these abnormalities then are numbered in order for us to be able to communicate with each other as to what sort of craniofacial abnormality the patient has. This wouldn't be required if you are referring a patient to plastics. We don't expect you to be able to tell us this is Tesla number 10, 7, or 3, but at least this illustrates the classification that we use. There are a number of different theories as to why this occurs. Again, a lot of genetic contribution is there as well, and they're also associated with some syndromes. The management or the goal is really to be able to protect vital structures and allow appropriate growth, and then be able to also then provide our patients with as best aesthetic result as possible. Now, when it comes to the patients that present to us, I've just included a picture here of one of those patients, and it can be quite disfiguring. However, we then approach it in a stepwise fashion where you look at your priorities and then you start to manage your patient according to that. So then you can look at the eyes and then manage that, and then go through to the mandible and the lip, and then we'll be able to actually then deal with each element separately, and then this will then give us an outcome that is a better aesthetic result. So from something that looks quite complex, we can actually break it down and manage these patients quite well, giving us a pretty good result at the end of it, and a good functional result, particularly if we get to see these patients early. This slide just illustrates the result of a repair of a cleft lip, which we spoke about initially, which is a bilateral cleft lip and a unilateral cleft lip, and the difference that it can make. Now, when these patients are with your craniofacial abnormalities, like you see in this one, again, I said we're just breaking it up into different elements, and then we can be able to get a pretty good result. At the end of it, the patient will not look absolutely normal, maybe, but it will be far better than they were before. And then finally, this is just a slide to show you the different people in the plastic surgery department, again headed by our Professor Dyer. And the bottom part of that slide just shows the registrars that are in plastic surgery, as well as Professor Madari, who is the outgoing head of department. And then finally, this is the slide of Vula. If you haven't loaded Vula yet, please do. you'll be able to find the Department of Plastic Surgery on Google, and this will give you direct access to the plastic surgery department, and you can be able to discuss patients or just get advice even for patients that you are managing. And then this will allow us to be able to actually co-manage and also get patients that need to come to Albert Lutuli sooner. We can then be able to ask you to send them to us as well. Thank you.
So, Dr. Ukzn, thank you very much for the very insightful presentation. Dr. Osman is joining us now. Welcome, Dr. Osman. Do you have any comments on the presentation?
Okay, thank you, Dr. Hannah, for the presentation. I think we might have information overload for the referral hospitals. But I think with repetition, it can become more familiar to nurses and physicians. Just a few things that I'd like to highlight is, especially when we have babies born with cleft lip, I think often they run to phone us to when they see these patients. And we need to bear in mind that they are associated abnormalities, and we need to carefully do general examination and exclude all of these because they're often small babies. And when you're looking at the cleft lip, we need to also look at the palate and refer to the pediatricians. I think all our patients do come from a pediatric outpatient department, and that's the way it needs to be. It's a timeline we follow for seeing these patients and the targets that need to be achieved. So we don't need to see cleft lip within the first week. We can see them at least at 2 months because we plan their surgeries at the age of 3 months. We need to be a certain hemoglobin and the target weight as well. And we also prepare cleft palates at 9 months. And when we have cleft palates, not often, but it does happen, is that some now and then, not often, have missed cleft palates. We're seeing them at 8, 9, 10 years of age, and we already have established speech abnormalities. It's very hard for them to really learn. So this highlights the importance of newborn examination, because a lot of these babies may be born in CHCs and not necessarily in the hospital. So we need to bear that in mind. And when it comes to craniosynostosis, when would you pick that up? It's also at a clinic visit, meeting a head circumference, lump stop painting, something doesn't work, or it's just an abnormal shape. Then you would refer to your pediatricians and then they would investigate further. So they are our gatekeepers when it comes to these things. They will probably do a CT scan and then refer on to us. And they would get the geneticists involved, physical, occupational therapy, speech therapy. And then one more challenge that we do encounter when it comes to the management of cleft lip and palates is that there's an ever readiness to insert an NG tube into these babies. And it's not necessary. We are able to swallow, and consulting speech therapy early on to assist the mom in teaching them how to position, taping of the lip, or choosing an appropriate bottle with the teeth for cleft palate patients makes a big difference, because if we don't allow the babies to stimulate them early on, it affects their swallowing reflex. So just to bear that in mind, especially with cleft lips, I think because it's so visible and daunting for the mom and the nurses, we often get distracted, and we shouldn't forget our basics in assessing these patients.
Thanks for that, Jasmine. Are there any questions from the audience? You're welcome to unmute. Tell us who you are, where you're from. Any questions at all?
You can post the message you someone to.
So just for those who didn't hear, it's just if there's any questions, you can just unmute yourself and then introduce yourself from who you are, where you're from, and then you can ask your question. We'll be happy to answer.
I think. So maybe Dr. Osman, I could ask. I'm very primary healthcare is my interest, and would be interested to know if mom presents to the PNC clinic in first instance. What would we do understand that a clip is it's obvious, but is it always obvious?
It's not always obvious, and sometimes it's never picked up because it's very grading. You get a microphone, it basically just a small notch, and even that is a subdivision to the severity. So they won't cause any functional problems, a very mild one. It's really just an aesthetic issue. So, but in the case of a cleft palate, can have a submucous cleft palate. You can pose as intent, but your muscle is not. And it's often the speech therapists that they know about it, so they're the ones who pick it up because the signs I can see like a grayish line within the palate. It's called lucidum, and there's notching of the well, that's something easy to see. That is always picks up in speech problems, not necessarily strong.
It's definitely pretty late though.
Well,
Yeah, well, the baby does when the child does begin
yeah, and then up to the age of 2.
up to the age of 2. Is that not too late to correct?
Well, we get them at even adults. So
Okay.
it is late, but yes, it depends on the speech abnormalities. First of all, we take into a healthcare provider to assess it, and if they've been sent on to speech therapy, which is also a challenge for us because we don't have enough speech therapists.
Maybe just to also comment on that.
Yeah.
Just to say that if you have a patient with a cleft lip, it's often associated with a palate. So just to use a spatula and open the mouth to just assess as well. And that also allows, early diagnosis or early referral to a speech therapist or a pediatrician or directly to us. And that will also just, expedite this.
Okay, great. So I'm just wondering, are there any particular points that you would like to share with the healthcare worker at PNC level, or quick diagnosis, or even have it, for those who even have a suspicion of signs and symptoms that could possibly be a differential diagnosis for either. That'd be obvious.
Yeah, I think the important thing is, if you're in a CHC or primary healthcare level, you're probably doing quite a lot of deliveries and you're seeing quite a lot of patients. And so my advice would be for that nurse or healthcare provider is if there are any abnormalities, regardless of if you're able to diagnose what that abnormality is, is to pick up the phone and just to call the pediatrician, which most hospitals will have at least one pediatrician available, and discuss the case. Or if you do have access to Vula, and taking a picture. And you can post a picture and say, I'm not sure what's going on here, but this doesn't look like the other kids that I'm delivering usually. And then a discussion can happen. Because there's such a lot of different abnormalities that happen in the head and neck area, cleft lip, the cleft palate just being one of them, it can be quite complex to diagnose. So I don't think the expectation is to diagnose it, but just to pick up that there's a problem. And then to remember that you've got access to consult. And that's the important part of it that everybody needs to remember.
I heard, I did hear you mention that there might have been, there are preventative factors that should be considered during pregnancy.
Yes,
Right?
yes. And I think this is what I think a lot of our health promotion is about, CHC levels, which is really to get assessed, to be part of a program, and to have your folic acid supplements, those sorts of things taken. It's important to avoid smoking.
Right.
And so these are the things that can be done. And if I think a lot of the cases of moms are part of a CHC program, this should be already something that's implemented there.
Is folic acid easily accessible at a PNC clinic level? Is it? Do we know?
Should be.
Okay, was it nurses
I
from?
don't know if somebody works. Does anybody work at a CHC or a primary healthcare clinic that can let us know if folic acid is easily accessible to patients? You can, sister, you can speak. You are unmuted. I'm not sure if the Lovo is trying to speak. Sister Nosipho Lovo, are you trying to say something?
Okay, I wonder if there's anybody else who can help us with that, because you know, we can promote these, but if these supplements are not accessible, then we need to take that to another level. Any other questions? How easy is it to access a speech therapist out of the urban center?
It's difficult in a tertiary center, but I can only imagine how hard it is in on
No? What would be the alternative?
Hello. Hello.
Yes, Simon.
Yes, Simon. I am from Ethiopia. I have one question actually regarding fibrous dysplasia.
Yes, go ahead.
Just in South Africa, either registered, how many cases are there that actually registered to the national book? Just the number of fibrous dysplasia. Is there any registered number of fibrous dysplasia that's classified as male, female in the National Registry Book of South Africa?
We don't have statistics in South Africa to my knowledge. I just know that there is a more predominant female to male predominance, but we don't have specific statistics on numbers specifically. I'm not sure.
Okay, thank you so much.
Ethiopia. Questions? Please. Here's your chance. Speak directly to plastic surgeons. Else you'd want to add adjustments? Do you have a question or a comment, perhaps? So I think just maybe guys not there. Pagaya, do you have a comment? No, it's not there. No, okay. All right. So just to say, thank you very much to Dr. Osman, Dr. Lukama, and to the Department of Plastic and Reconstructive Surgery for hosting the very first Echo Outreach session for 2025 in the School of Clinical Medicine. So the department is actually hosting a series of conditions that they address as part of their surgical intervention. And the next one in the series is on Monday, the 10th of March, where there will be a presentation on skin tumors. And I urge you all to attend, and also we will be sending out the invitation shortly. But also to invite your colleagues from the clinics, from PHC, to also be part of this very important discussion. Okay, with that, I just want to say again, thank you to the Department of Plastic and Reconstructive Surgery, to our hub members, Echo India, to Prof. Loga for taking out this beautiful room for us, actually, and to the College of Health Sciences IT support team, and the School of Clinical Medicine Administration. I want to say thank you very much for your assistance in putting this together, and until next time. Goodbye. Thank you.